Position the patient supine on a stretcher. Briefly explain the procedure to the patient if he is conscious. As you prepare for the thoracostomy, have other members of the care team place the patient on oxygen and a cardiac monitor, and establish large-bore intravenous access. Preparations for chest tube insertion and portable radiography to be performed after the procedure should also be made. Standard intravenous catheters are suitable for needle thoracostomy. 14 or 16 gauge 5 centimeter catheters are ideal. Catheters without safety mechanisms, such as retracting needles, are preferable since they will allow for free return of air from the backside of the catheter. If using such a catheter assembly, remove the cap from the flash chamber prior to insertion. A syringe, which allows for aspiration during insertion, may optionally be attached to the back of the catheter. The use of a syringe provides tactile feedback during catheter advancement. Begin by palpating the anatomical landmarks. Anterior needle thoracostomy occurs in the second intercostal space in the midclavicular line. To identify the second intercostal space, first palpate the sternal manubrial joint in the anatomic midline. The second rib articulates with this joint. The second intercostal space lies below the second rib. Needle insertion occurs over the superior surface of the third rib. Mark the insertion site with a skin marking pen if desired. Next, prepare the site with a skin cleansing agent such as chlorhexidine or povidone iodine. If the patient is conscious and stable, a wheal of local anesthetic may be injected over the needle entry site. This should not be done if the patient is hemodynamically unstable or if there is significant respiratory distress. Insert the catheter assembly perpendicular to the skin in the midclavicular line along the superior surface of the third rib. The inferior surface of ribs must be avoided due to the neurovascular bundle that is located in that region. Advance the catheter assembly into the thoracic cavity until air is aspirated from the syringe. If you are not using a syringe, entry will be heralded by a rush of air through the catheter. Stop advancement immediately once air is returned, and then carefully guide the catheter over the needle and into the chest. Remove the needle from the catheter and dispose of it in an appropriate manner. Preparation is identical for the mid-axillary approach. The ipsilateral arm may be placed above the patient's head to grant access to the region. Needle entry occurs in the fourth or fifth intercostal space in the mid-axillary line. Try to directly palpate and count the ribs beginning in the axillary fossa. In most adults, the fourth or fifth intercostal space is at the same level as the nipple. Needle insertion occurs over the superior surface of the fifth or sixth rib. Mark the insertion site with a skin marking pen if desired. Prepare the site with a skin cleansing agent such as chlorhexidine or povidone iodine. Local anesthesia of the area is optional and should be considered in the stable, awake patient. Insert the catheter assembly perpendicular to the skin along the superior surface of the fifth or sixth rib. Entry into the thoracic cavity will be heralded by aspiration of air if using a syringe, or by a rush of air through the catheter assembly. Stop advancement immediately once air is returned, and then carefully guide the catheter over the needle and into the chest. Remove the needle from the catheter and dispose of it in an appropriate container. Successful needle thoracostomy will transform a tension pneumothorax into a simple one. Subsequent chest tube insertion is mandatory to prevent recurrent tension pneumothorax. If a return of air is not achieved, consider repeating the procedure with a longer catheter, especially if the midclavicular approach was used. Alternatively, a tension pneumothorax may not have been present, and you should consider alternative diagnoses.